an IVU sponsored pandemic edition of the Virtual Visiting Professor. The New York Times recently reported that coronavirus has surged 24% in a matter of days after a 3-day lockdown was eased in Ghana's two largest cities. This was reflected in testing that was done during those 3 weeks of lockdown prior to. So what does this mean potentially for healthcare in Ghana? This morning here in the United States and in an afternoon in Kumasi, Ghana, and other parts of Africa and the Caribbean, we have a panel discussion of urologic experts to discuss what urologic patients may face in the midst of a COVID pandemic. Joining us today is Scott Egner, who is a professor and vice chair at the University of Chicago, Dr. Jay Smith, who is an emeritus professor of urology at Vanderbilt and the editor of the prestigious Journal of Urology, Stacy Loeb, who's a professor at NYU, who does urologic oncology, and Ariba Sadiq, who's a fifth-year resident, volunteering, doing ECMO at NYU for the last month. So I want to thank everyone for being here. And Scott, I'll let you take over.
Yeah, hello, and most importantly, well wishes to everybody. The purpose of today is to download some information from the experience in the U.S., prompt some questions and inquiries, and sharing some stories from what's going on in your part of the world as well. Obviously, there's tremendous regional variation, even within the United States, depending on where you are. There's places that are very hard hit, and there's places that have barely seen any cases. And you have to adapt, obviously, to what the situation is with the incidents in your community, the resources at your hospital, and a lot of other factors. Just briefly, at least in the United States and many people elsewhere may know this, testing isn't perfect. And at least at our place, the nasopharyngeal swab only has about 70% sensitivity. And so everyone is getting tested twice to get ruled out to make sure they don't have it. Some things that might be useful for other sites, we've actually had drive-by testing. And then there's obviously tremendous interest in antibody testing. And we could go on for 30 minutes about antibody testing, but there are tests available, but there are tremendous limitations on some cross-reactivity, as well as once you have detectable antibodies, are you still able to transmit it to someone else, and what kind of durability there is to your immunity. The main thing I wanted to download before we just turn it over to others and then hopefully have a discussion is that, we shut things down in Chicago pretty quickly. And we were basically doing no clinic, no ORs, except for true urologic emergencies. And then our numbers now have stabilized. We still have about 120 people in the hospital with COVID, but as that's happened, we've incrementally increased the amount of what we call medically necessary, time-sensitive urologic surgeries. So at one point, we had 0 ORs for elective surgery. Then we had 2, and now we're up to about 16, whereas normally we have about 30. All of our COVID patients are on 2 floors. Some things that might be useful for other sites that we've done when we've started doing some surgeries, such as larger kidney tumors or cystectomies or RPLNDs for testis cancer, are that we mandate that all patients coming in from the community undergo a COVID test and are ruled out to be negative. We have precautions in the operating room where during intubation, the entire team is outside the operating room except for the anesthesia team, who have next level, protective gear. And then for 10 minutes afterwards, the surgical team is not allowed in to try to let any aerosolization during intubation subside. And then obviously patients go to an area of the hospital without COVID. There's N95s available for the surgical teams. But perhaps the one thing that could be most useful, and we've instituted this throughout our entire Department of Surgery, and I'm just going to post it for you, and this will be the last thing I will share before I turn it over to others, is this was not from myself. This was from others in our group in the Department of Surgery. But when we started adding medically necessary time-sensitive surgery, every surgery that was going on in the OR, it had to fill out this worksheet. And it's a scoring system on how to triage cases. And it had to go in front of a small committee to get approved. And there's 3 categories, and we won't go through everything, but the top is the procedure score. Is it a high risk or low risk procedure for COVID? And it had to do with OR time, the body cavity. Is the patient going to be in the hospital for a long time or short time? Then there's a disease element to it. Does the patient need the surgery immediately? Will 2 or 6 weeks make a difference? Are there other options besides surgery? And then lastly, what's the condition of the patient? And what is their risk of, if they were to get COVID, how risky would it be for them? And then you add these up, and so we have numbers on how to, triage what cases might be higher or lower priority, higher or lower safety. And I'm happy to share this with anyone. Just send a message to Josh, and I can distribute it if it would be helpful. I will turn it over to Dr. Smith. For the sites anywhere that are following along, feel free to post questions on the chat on Zoom. We can do things that way, and then we will also take questions after each presenter, and you can do those verbally as well. Dr. Smith?
Yeah, all right, good. Thank you. So they asked me to speak about some of the literature on COVID, and as Scott mentioned, there's just tremendous variability in terms of the impact of this virus worldwide, obviously, and as he mentioned, in our country. But it's really interesting when we look at some of the published literature, because there's an incredible commonality amongst it. And that's because virtually all hospitals have very quickly adapted very similar guidelines. Scott outlined some of the things we're doing at the University of Chicago. Every other hospital that I know about is doing that. Some of those guidelines and some of those recommendations actually originated from China, from Wuhan, where they did some of those things at their hospitals. But now all regulatory bodies worldwide, European, the American College of Surgeons, the National Cancer Guidelines, all have issued different regulations and guidelines for not only how operating rooms should adapt, but how they should triage cases. So anywhere around the world, somebody can get access to those, and you can then adapt them to your hospital as necessary. Now, one thing to think about is why we restrict urologic care during this crisis. And there are multiple reasons for it, actually. One of them is to preserve hospital resources. And that's where you really need to look at your own hospital. You're going to see varied experience. We're going to have some of our colleagues from New York talk where they've truly been in a crisis and have not had sufficient available equipment or available hospital beds, as opposed to my hospital at Vanderbilt, where we had even converted an entire floor of our parking garage into an emergency hospital, and we've never had a census of more than 20 or 30 COVID patients throughout the entire time. So we've basically been sitting around with an empty hospital. Nonetheless, almost everyone agrees it's better to over-prepare. So you need to look at your current situation and what hospital resources you need to secure and have and not use up taking care of non-emergent urology cases. So one reason, preserve hospital resources. Another reason, protect hospital personnel. You've seen it everywhere. So many healthcare professionals themselves have gotten the virus or have died from this. And obviously we want to protect personnel from patients who may come in and who are infected. And the third one, of course, is to protect patients, so we don't put them in an environment where they themselves could get COVID from others around them, and in particular, as everyone has learned, one thing we don't want to do is perform surgery, even relatively emergent surgery, cancer surgery, or completely non-elective surgery in a patient who is COVID positive. And so there have been some pretty sad examples that have occurred. I'm aware of a couple of patients who had robotic prostatectomy, something that would almost always be only a semi-elective case at best. They had tested negative prior to their surgery, and then 2 days post-op had fulminant respiratory failure and actually died and proved to be COVID positive. So one thing we've all learned is that screening patients as much as possible for COVID before subjecting them to an operation is really mandatory. So I mentioned there's a real commonality amongst many of the, much of what's published in the research in urology. You know, it's interesting, the Journal of Urology, of which I'm the editor, we've had almost double the submissions over the last 2 months. Now, some of that's, I think, because people are not as busy with some of their other activities and they have time to put together some of the papers they otherwise might have been holding off on, but also because we've gotten probably 100 manuscripts related to COVID just over the last couple of months, which is terrific. And many of them are posted online, others are in process. And again, some of them are about triage of cases. And again, I don't have to go over all of that because you can very easily get resources for triage of cases online. Some of them are about hospital practices. Scott outlined some of them, but they've become very, very routine almost throughout the world as far as how hospitals are trying to preserve resources and protect patients and personnel. We had one interesting one where they looked at the shed of COVID in the urine. Other coronaviruses, SARS and MERS, are not shed and are not spread apparently through contact with the urine. The literature with regard to COVID-19 is still pretty sparse, but it does not appear that there are any active infectious viral particles in the urine itself. Now, that doesn't mean, of course, that you don't maintain the highest level of precaution with any bodily fluids from any patient, but especially one with suspected COVID. But nonetheless, it appears that urine is not a vector or spread of it. But that's not to say that the urinary tract itself is not affected, because there has been renal insufficiency and renal failure in patients. Some of it because of just general multiple organ failure, stress on patients, but also an interesting paper which we're going to be publishing here shortly that showed that the viral particles actually have been shown to replicate within the kidneys. Now, why that would occur and then not have them be within the urine as an infectious source is a little bit unclear to me, but it does appear that there can be direct renal damage from the virus itself as opposed to just the general systemic effect. So urologists do have the luxury, and many of our patients have the luxury of delaying much of their care until crisis situations have passed, but not completely. We all know what emergent urology is, and so when that needs to occur, it needs to occur in cautious situations. And again, as our colleagues from New York, I'm sure, are about to tell us, urologists in some centers where the crisis is even greater need to take on an even more expanded role. So I would encourage you to continue to review all of the literature, manuscripts published in the Journal of Urology, as well as the other leading journals, are available online as soon as they are accepted. So there's no 2 or 3 month delay. It may be July until they occur in print, but they're available online immediately. So I would encourage you to continue to check for multiple urology-related journals for some of the online publications so that you can stay abreast of any new changes. All right, thanks. And I'll turn it back over. I want to leave as much time as we can for discussion because, again, so much of this is really going to depend upon the localities where you are.
Thanks, Dr. Smith. Let's move over to, actually, if there's any questions, feel free to post them on the chat on Zoom. It's on the bottom. Or ask directly to Dr. Smith. But if there isn't anything at this point, we'll move to Dr. Siddiq and Dr. Loeb, who are in the epicenter of US COVID, and that's in New York and New York University Hospital.
Okay, so I can start. Good morning, everybody. I have a few slides, so I'm just going to share my screen just to help contextualize the discussion. Let's see. Okay, so so I'm Stacy Loeb, and this is our COVID totals in the USA. We've had over 1 million confirmed cases and 65,000 deaths as of this weekend. New York State has been particularly hard hit. We've had more than 300,000 confirmed cases, of which 174,000 are in New York City. So quite a large proportion. But you can see it has decreased some in terms of the new positives over these last days. This is the similar slide for deaths. There have been over 19,000 confirmed COVID-19 deaths in New York State, of which more than 13,000 of those are in New York City. In terms of our local timeline, on March 15th, the New York City mayor signed an executive order to postpone elective surgery. So at any hospital in the area where it wasn't already being held, this was officially the end of pretty much all of our urologic surgery. So there's been very few cases since March 15th. On March 17th, we converted all of our conferences to either video or suspended them for education. Our health system rolled out telehealth system-wide on March 19th. So we've done most of our clinic activities, in some cases all clinic activities, through either video visits or telephone when that's not possible. And then on March 29th, all of the urologists in our department were assigned a rotational schedule for deployment in COVID care among one of our 3 hospitals. So we're all still officially redeployed, although not everybody is needed at this time due to some decline in the cases. Now, there has been an updated surgical policy in New York State as of April 21st, where some hospitals were allowed to resume elective surgery April 28th if they met certain criteria based on the hospital capacity and the number of new hospitalizations in their county. So this does not apply to New York City, but there's some areas in upstate New York and other parts of the state with many fewer cases, and they're actively monitoring these. So if at any time you start elective surgery, but you no longer meet these criteria because there's a surge in the cases locally or your hospital capacity is less, then you have to stop again. And all patients have to test negative for COVID before any surgical procedure. So in terms of urologist deployment in our department, it's really varied a lot. Some have been in the ICU. Some have been functioning as an inpatient hospitalist, whether or not the patients have COVID, sometimes just to assist with other cases in the hospital. Others have been on the inpatient medicine ward, in the emergency department, helping with testing for COVID. And there's also some urologists who have assisted with telehealth by helping to screen patients who call in with symptoms, whether they meet criteria for testing. Our institution also has a whole lot of clinical trials going on with COVID. So my Department of Population Health, where I have a joint appointment, is involved in running a bunch of these. And some of them are actually eligible to physicians at our institution. For example, prevention trials of people who have potential exposures to COVID. There's prophylactic trials, but there's also a bunch of inpatient clinical trials that patients can be enrolled into, looking at some of the different possible treatments, as well as methods to try to reduce the immune overreaction to COVID and managing downstream complications of COVID, because in particular, it seems like there's a lot of clotting disorders. So there's a study on anticoagulants. We've also been actively involved in some of these online education activities since all of our in-person conferences had to stop. I just want to highlight this because it's a very nice lecture series from New York State, but we've had a lot of great professors from all over the country. And you can see down in the lower right of the slide is the Zoom information if anyone would like to participate. I think these are some wonderful lectures. I have one on Wednesday on social media, so if you'd like to join, please do. So in terms of my own role personally, I've done some shifts with the internal medicine team at the Manhattan VA, basically serving as like another intern to the medicine service, helping them with calling consults and other things for the COVID patients. Actually, it's very tightly restricted where they try to keep people out of the room. So typically only one person from the team goes into the patient room per day, unless there's a really important reason. Otherwise, most of the communication with the COVID inpatients is via their bedside phone or their cell phone. So we keep a list in the team room with all the patients' bedside phone numbers and cell phone numbers and their families' phone numbers. So a lot of the time is spent talking to the patient or their family on the phone, since we're trying not to go in. Otherwise, I've been doing continued urology care via telehealth, which has been fantastic and probably one of the shining lights to come out of this. Remote research activities when possible. We've also had an institution-wide halt on human subjects research. You're really not allowed to bring anyone to the hospital or enroll any participants in studies. So it has also caused a pause on urologic research, but non-human subjects research can continue remotely. So that's all from me. I'll let Ariba go next, and then we can take questions.
Good morning, everyone. Thanks again for the invite to be a part of this discussion. I'm going to go ahead and share a couple of slides here. I think Dr. Loeb's presentation was a great segue into some of the more clinical aspects I wanted to share from my experience. So, 1 second. So I wanted to go over just the ICU experience that I had been a part of this past month, some of the presentation, the ICU structure of the teams, some important information regarding ventilator allocation, which had come up during my time there, as well as some common problems in the COVID patient population, specifically in the ICU patients, and very briefly, the role of ECMO, which was specific to the ICU that I was volunteering in. So when I had joined at the end of March, and just to go over some of the brief numbers. So when I had started, we had probably about like 50 COVID ICU patients and about 200 or so COVID floor patients. We ended up peaking in about early April at our hospital, where there were about close to 190 COVID ICU patients and close to almost 600 COVID floor patients. As of yesterday, things have sort of plateaued and are sort of now on the downtrend. So as of yesterday, we have about 130 ICU patients and about 330 floor patients. So we are having a good amount of discharges and some transfers over to long-term care facilities. So in about March, NYU published a very short report going through the number of patients that they had tested across about 4 hospitals in the NYU system. So amongst about 4,000 patients that tested positive, again, these were the nasal swabs, approximately half of them were admitted. And of the half that were admitted, about 50% of them ended up getting discharged. And there was about a 14% mortality rate, or patients who ended up getting mean hospital. From that review, we found that some of the strongest risk factors for hospitalization were age over 65 and obesity, so BMI of greater than 40. And some of the risk factors for patients that ended up requiring ICU care and were in critical states were elevated inflammatory markers and then a presenting O2 stat of less than 88%. So by the time they came to the ICU, they were either the ARDS was just so severe that they were already intubated or coming up to get intubated. And so because our volume was so high, I think the ICU team structure was very important to streamline some of the workflow. So we actually had a separate ICU intubation team and a line team that was required, that would come in to assist us with tubing these difficult patients, and then also placing central lines and A lines. There was a specific anesthesia prone team, which was important, that were responsible for securing airways when we were proning patients onto their stomach. And so we had a specific protocol of proning where patients would stay on their stomachs for about 16 hours of the day in order to increase perfusion and ventilation of their posterior lungs, and then about 8 hours in the supine position. At a certain point during our peak, we had a tremendous need for nurses. So typically in the ICU, we now have a ratio of nurse to patient, ICU patients about like 1 to 2. Normally pre-COVID, there was usually about a 1-to-1 ratio. And so there was a tremendous need of nursing care that was buffered by these traveling nurses that came in to assist us. There was, of course, the in-house clinical team, so the staff of like residents, fellows, attendings that took care of the day-to-day. Then we also had a remote team for that served as sort of this liaison to the families in order to give them updates of how their loved ones were doing, what were the plans for the day, review any pertinent lab and imaging with the families, in order to sort of offload some of the work from the actual in-house clinical team. And then lastly, there was a good, very strong clinical trials team. So all of these patients were mostly enrolled in the studies that Dr. Loeb had mentioned. And so they were responsible for consenting family members and making sure that all of the criteria were met for these trials. And so by the time, they came onto our floor, again, they were already intubated. There was a certain point in early April, I remember we were at a point where we were discussing the potential need to share ventilators. And I think this may be kind of pertinent to some of our international colleagues. Thankfully, we ended up not needing, not really having a ventilator shortage per se, or the need to share ventilators, but we did get several ventilators sent over from our governor. From the state. These are some of the common ventilators that we were using in the ICU. So the Servo U, which is probably the most common ventilator amongst recent trainees, it has a touch screen, you can see waveforms pretty easily. However, there were a little bit more older models of ventilators that were coming through, along with this LTV model over to the left, which is a model that typically is used for patients who have long-term trachs. And so this was a learning curve for any of the non-ICU or crit care physicians coming in to be able to sort of manage multiple different types of ventilators and settings. And so we were at a certain point sort of prepared to have to make this decision if we ever needed to share ventilators. And so New York State actually published a ventilator allocation guideline. This was back in 2015, mostly in response to the H1N1 outbreak a couple of years prior to that. And so the SOFA score is sort of this mortality risk score that we were using, and it's based on a couple of these variables and lab values out and to the left. And based on this SOFA score, then you are placed into these colored groups that determine your level of access to ventilator care. And so those in the blue group were essentially very, very sick, high SOFA scores, were likely not going to make it. And so there was no recommendation for ventilator support. And these patients were patients that you could, would probably benefit from a palliative care discussion. The patients in the red group were very low SOFA scores, so not a lot of organ failure, potentially would do pretty well if ventilated, and had low mortality risk, and so they had the highest priority. The yellows were at the in-between, kind of sick people, but also very intermediate mortality risks, and then the greens were patients who did not need it, any ventilator support. And so this was sort of a guideline that we were prepared to use. Thankfully, it didn't come to that. That being said, I think a lot of the medicine attendings on the floors had to have certain discussions with patients who are close to intubation with their families in order to see if intubation was truly something that they had wanted and were a part of these guidelines. And so after they were intubated, we started noticing that we were having a lot of problems, and these are sort of some common clinical issues that we were encountering. So after they were ventilating, we were noticing that there was a significant amount of secretions and mucus pluggings. A lot of these people were getting frequent bronchoscopies, frequent ET changes. Even after we were converting to tracheostomies, there was just a significant amount of secretions. Because of this, a lot of these patients were put at risk for having very high peak airway pressures, and there were quite a few patients that ended up having some ventilator-associated lung injury. These patients demonstrated very high hypercoagulability. There were a lot of patients who had PEs, DVTs on the floor. Anecdotally, I remember one of my first couple of nights when I was placing central lines, you'd place a needle, you'd allow some of the blood to drip through, and it would just completely clot off the needle, clot off on the tray completely. And so we put together a short little guideline for anticoagulation in the hospital based on D-dimer levels. And so those below the 2000 level, we were giving prophylactic doses of Lovenox. Those above the higher thousands ranges and into the 10,000 ranges, we're getting the therapeutic Lovenox dose. And some of this is also pertinent to what Dr. Egner was saying and Dr. Smith was saying with regards to our post-op patients who are oncologic post-op patients who potentially could be exposed to COVID in the community, who are then going to potentially develop this hypercoagulable state and put them at risk for post-op DVTs and PEs. We were seeing a lot of infections and sepsis requiring pressors. About days 7 to 10, we were seeing the cytokine storm with high fevers, AKIs, increasing ventilator support, probably due to some sort of like cytokine-mediated injury of the lung, and then getting superimposed bacterial infections. There were a few aspiration pneumonias from the tube feedings that we were giving. And then along with a lot of these fevers, we were concerned about line infections. And so Candida was candidal infections for those who had lines for like greater than 10 days was starting to show up. Pressure wounds were also noted. So nurses were actually required to turn and kind of shift patients' weight Q2 hours as best that they could. And obviously it wasn't a full turn. It was more so just like padding to shift some of that weight. Renal failure, which I had mentioned, a lot of people ended up becoming oliguric and requiring CVVH. One of the challenges for CVVH is that the units were not available in the numbers that we needed. And so we were actually sharing units between patients. So instead of doing a 24-hour continuous dialysis, we would do like 12-hour shifts and share it between two patients. And then mental status assessments, obviously very difficult in patients that are intubated and paralyzed. There was a great story of this nurse who, a very astute nurse who did a very good mental status check, actually checked pupils, noted that there was some asymmetry. Sure enough, that patient ended up getting a non-con head CT, and we ended up finding that he had completely stroked out and lost half of his, one of his hemispheres. And then lastly, I just wanted to bring up ECMO, or extracorporeal membrane oxygenation, which was sort of specific to the ICU that I was working in. Just very briefly, it's essentially like a 30 French cannula into the SVC, and then another 30 French cannula into the groin, into one of the femorals, and then through this circuit, you're removing. It's just essentially like a bypass where you oxygenate your blood and put it back into the system. There's two sort of forms of it. There's VV ECMO, venous, which is the most common used, and there's also VA ECMO, venous arterial, for those patients who need a little bit more cardiac support, to those who've gone to cardiac failure. The actual ECMO unit was placed by the CT surgery teams at bedside. Some of the major exclusion criteria is obviously refractory multi-organ failure and septic shock. So, the team would not necessarily be placing ECMO in, an elderly patient who had severe, AKI, liver dysfunction, versus like a healthy 30-year-old. And obviously those are sort of two extremes. Some of the gray areas and some of those patients in between were sort of a decision, a case-by-case decision that the CT surgery team had to discuss. It is a very expensive resource. It requires, a separate consult, a lot of disposable items. There's a perfusionist team that's also needed. So it is a very expensive way of saving, of providing this kind of support. And some of the major complications associated with it are hemorrhage and infections. And so we had to sort of weigh the risks and benefits and really ideally pick out patients that we think would end up having low mortality and really recover from resting their lungs and recover from ECMO. Our numbers at NYU, we had about 25 cannulations so far. 10 of them have been discharged, actually. So promising. That they haven't officially published any of that just yet. But in comparison, there have been some studies done in China and the Wuhan area with regards to ECMO. Unfortunately, they did have a lot of, I think they mentioned about a 40% mortality rate because of end organ failure and sepsis. So it is very site dependent. And then lastly, these are some pictures from some sidewalk chalk art that New Yorkers had left for us, which were nice to walk into work and read some nice messages on the sidewalk every once in a while. So that's about it.
Thanks, Dr. Sadiq. So I can tell from some recognizing some friends and colleagues elsewhere, we have people joining from Ghana, Nigeria, Uganda, Saudi Arabia. I'd love to hear input from them on any specific questions they might have, comments or experiences in their own part of the world. Dr. Loeb and Sadiq, one of the disheartening things that came out of Italy were the high number of physician deaths, over 100. Have you been seeing the same in New York? And if not, any particular hypotheses why? And do you want to just touch on what the personal protective equipment is like at your hospital, and any recommendations for, high resource and low resource settings?
There were a handful of physicians actually on our ECMO ICU unit, unfortunately, and that's sort of the hardest because these are colleagues that we worked with and have known over the years. There have been a lot of residents that on the workforce as well who had gotten sick and fallen ill and needed some time off. That being said, I think once the initial chaos of the pandemic kind of settled out, we were doing a lot better job of using PPE. And so it's pretty standardized in the ICU, where everyone has an N95. The recommendations were to keep our N95 for about a week's time, and we are able to reuse them as long as it's not grossly contaminated. Everyone gets sort of a face shield, which one of Dr. Loeb's images showed, and then gowns were used as well. We started having a little bit of a gown shortage by the end of it, and so the recommendations were, if you're not touching the patient and going in just to change ventilator settings or drawing off of a line, then a gown would not be needed in order to sort of conserve those resources.
And so when you say an N95 for a week, you would wear it all day at the hospital, bring it home, put it back on the next day?
So we would wear it on all day and then put it into a brown paper bag, leave it in the hospital, and then use sort of a soft mask to leave the hospital in that way that we could preserve that N95. As long as it sort of had a full seal, and you'll start noticing by the end of that week's time that seal starts getting a little bit loose, and you don't have that indentation on your skin anymore. That was usually a sure sign that we needed replacements.
Yeah, I think what we have been doing is using the brown paper bag, like what people traditionally used as a lunch bag for children in the United States. So what we did is put them in those bags, and you write your name and the date of the mask on there. And if there is enough that you can use another one, then you know when your old one was last used. So if there's sufficient PPE available to rotate it, if you're able to sort of quarantine the N95 mask for a few days, or if you have a few days between your shift. So I would take off mine and then retire it for as long as I was able to, and then use the oldest one that hadn't been used in more days again for my next shift.
We have people from different specialties on, and it obviously depends on if you're in a high prevalence or low prevalence area. I can tell you from a cancer standpoint, in a fairly high prevalence hospital, we shut down basically all prostate cancer surgeries. We did prioritize some cystectomies, an occasional large kidney tumor, or a unique RPLND. And as hopefully everyone's aware, there actually is a rich literature on time from diagnosis to treatment for many of the cancers we deal with. And the first month or two are relatively straightforward. The hard questions, from my standpoint, come when you get outside of 2 months. And I just want to lean on some other people from different specialties, and Dr. Schneck and Dr. McCammon and peds and reconstruction, and Dr. Smith and Loeb from cancer. Presume you're in an area where you have to triage which cases, which in those specialties would you say are higher priority, time sensitive, versus ones that should just slow play and kick the can down the road? Fran, do you want to start with peds, and then maybe Dr. McCammon for recon?
Sure. I think what I realized in the pediatric realm is that most everything we do is elective. There's very few emergencies, septic stones, tumors, and of course something like torsion. But testicular torsion is really not much that's so time sensitive. And effectively, our division here has been shut down. Recently, our hospital has decided that elective can be broken up into essential surgeries, meaning that there's electives that some are just elective that can be done anytime, and then the essential electives, which means that effectively down the road something could be harmed by waiting a month or 2 or 3. Again, I don't think that pertains so much to pediatric urology, but things like undescended testes were considered that. But for the most part, we've been essentially quite quiet until this week. We haven't seen the same numbers anywhere close to it here in Pittsburgh that New York or even Philadelphia has seen.
Hey, Scott. Thanks. Reconstruction is pretty much the same. As you can imagine, there's not much that we really needed to do acutely. We had a couple patients that were going into retention from urethral strictures, and we either placed an SP tube or did a dilation in the office, understanding that we would push them back a little bit for their repair. But there's really nothing acute that we needed to be taking care of at this time. And so the reconstructive urologist, at least in our group, were more of the office-based urologists seeing the acute care patients and helping out our other partners who are doing the cancer stuff that still was getting done.
Comments from overseas. I'm going to call on Dr. Arhin, Lawal, Dr. Rava, Dr. Maison. We're interested in hearing from you or anyone as well. Any specific comments, questions? All right. Well, thanks for joining. If there's anything else anyone wants to add, I would just thank everyone.
Yes, hello. I'm sorry, the connection was bad. Can you hear me?
Yeah, Danny, we can hear you.
Yeah, hi. Sorry to bother you. Just wanted a quick question by you. Trust biopsies. So you have a long list of patients who are waiting for their trust biopsies. We know that feces of COVID patients is loaded with virus. Have you been doing any in a more elective setting out of epicenters such as New York?
I can share our experience, and then I'll ask the Dr. Loeb. We shut it down for about 2 months, 0 biopsies. Okay. And now what we've done is we've opened it up to some of the higher risk folks, and their only exposure within 2 meters of anyone is actually with the person doing the biopsy. We started offering it to people, and I'd say 50% of the people decided to come in to have it done, and the others said, no way, I'm coming into the clinic. Dr. Loeb?
Yeah, we basically shut down the biopsies from March 15th or so onward. I think there's been about 4 total since then. So I would recommend trying to avoid it, if at all, if it's not absolutely urgent, to guide care.
I don't think they ever are, but my question is, even when you do open up, will you be doing a PCR for every patient, since this is considered by at least gastroenterology when they do colonoscopies or gastroscopies as an aerosolizing procedure? So will you be requiring a PCR before doing the biopsies?
I think if it's feasible in your context, that it would be ideal to have the patient test negative, just like for any other surgical procedure. So if feasible, I think that's the best approach, and also wearing an N95 mask if that's available for this, and keeping as few people around as possible.
Okay, sounds good. Thank you.
Danny, what's the situation in Riyadh?
It's confused. It's very confused. We're averaging around 1,500 cases a day. However, we started opening up. We're in curfew for 16 hours of the day, and economically speaking, things are taking a big hit. So they have decided to control the curfew. We haven't had as many sick patients as you guys have in the US. Less than 10% are hospitalized, and our supposed death rate is less than 1%. But we're not testing as much as you guys are yet. So we're hoping to ramp up the testing to be 60,000 per day. We're still at only 20,000 per day. Hello?
Yep. Anyone from Africa? Many participants. All right, Fran, I'll turn it back to you.
Hello. Hi, this is Dr. Hin from Ghana.
Hey, Dr. Ian, how are you?
Morning. I'm fine, Snake. And hi, it's Pittsburgh.
Nice to see you.
Great, great.
The last time I saw you, you didn't have any gray hair. See,
Yeah, I'm green now.
and I see Dr. Aboa is there too. So Dr. Aboa, and
That's right.
yeah, that's wonderful. It's great to see you all.
Great,
Thank you
great
for
to see you.
thank you for asking for this. This was helpful. It was able to bring together people from the United States to talk to you all. So, how are things in Kumasi, Ghana?
Fortunately, we haven't had such large numbers that needed ICU care. So far, none of our patients has really needed critical care at the ICU. Most of them are treated at the isolation centers. And in Kumasi, as we speak now, we've had about 3 mortalities from COVID since it started about almost 2 months now. Most of the patients have not had to go to critical care units, as I said earlier. And that was the more reason why we needed something like this to prepare us in case something like this should happen to us. For our experience level at this moment is quite low because we haven't had to deal with such large numbers of critically ill patients. Thank you.
Thank you.
Yeah.
Yes, thank you, Dr. Ahin. That's a good picture of what is happening.
That's right.
We still continue with some elective surgeries. I'm asking whether it's advisable that urologists will test. Although we may be asymptomatic, should we test to protect our families, to make sure we are still negative?
Dr. Loeb, you want to take that one?
Sure. I mean, I think it's depends on the availability of the test. There have been very strict guidelines for us as to who can get a test. So it hasn't always been easily available for providers to get it unless you have either symptoms or a positive contact. The only time that it's been opened up to me personally, since I haven't had any symptoms or a known high-risk exposure, is because now they're looking into plans for trying to start reopening some of the clinical locations. So one of my clinical practice sites is at one of NYU's hub locations that they're opening first as a triage place where people will go, and all staff in the building have to be tested before the reopening so that the patients can be told that all of the staff have tested negative who are there. So up until then, I didn't have a way to get a test for myself just to check for the purposes of my family or other contacts. So as a result, I didn't see any of my family for the entire time of helping with this.
I do want to emphasize something Dr. Smith mentioned that might be relevant for other sites as you start seeing more prevalence in the community. We had an unfortunate case at our hospital, and I'm aware of about 5 or 6 others across the country of people that felt well, came in for a semi-elective, thought to be a medically necessary surgery, and unknowingly had COVID, and the process of intubation and surgery set off a cascade that led to death. So if you have resources available at your hospital and there's enough prevalence in the community, I think everyone would strongly, strongly recommend that people get tested before any time-sensitive surgery.
I'm gonna just add one comment. I was on a webinar last week with Professor Montorsi, and at his hospital, they're also doing chest CT scans right before major surgery as an added way to ensure that there isn't any changes suggestive of COVID. So that could be either an alternate option if that's more readily available than testing, or could be added if there's a clinical concern.
May I ask a quick question, please? Regarding healthcare workers who are immunocompromised on some immunocompromised medications, such as for Crohn's disease or whatnot, who are not in the front line, such as urologists. Have they been staying at home or have they been working?
In our context, most of those individuals have been staying at home and have not been. One urologist that we know even decided to retire early because he's over 70, so he's at higher risk, and he didn't want to come in for several months. So even though he wasn't planning to retire, he announced it suddenly at the end of March. There's another local urologist who had leukemia and is immunocompromised. So he still wanted to help. So he's doing the telephone screening line instead of volunteering in the hospital. So I think there are ways to still get involved, such as helping with some, telephone messages. As Dr. Sadiq said, there's a lot of need for communication with families and liaisons to other parts of the care team if there is COVID happening. So there is definitely opportunities for people to help with phone and other kinds of remote activities. And then for urology, I've found that many of the conditions that we treat are very readily suitable or temporizable through telemedicine. And people have used all different things. Some people are just using FaceTime or Skype. Others have a full telemedicine program available through their electronic medical record system. So depending on what kind of setup or even telephone that's available, I think that would be another way that they could practice.
And are you able to bill through the telehealth system?
We have emergency regulations that came out of the United States where Medicare and other payers are now allowing billing. So the video visits are billed the same as a regular in-office consultation. Telephone calls are not billed the same, but you can bill for them with most payers in our area. So it's less reimbursement if it's a telephone instead of a video, but you can still bill for that.
Okay.
Danny, at our university, every physician was asked to be ready to redeploy, and what they did is based on age and health. There were 3 tiers, and the first tier was sort of the first wave based on obviously the youngest and the healthiest.
Yes, that makes sense.
My advice is to ask all of your faculty preemptively, just their own, whether they have any contraindications, and also their preferences, because I would say in our department, as you can see with Dr. Sadiq, there are some people who, have been amazing and doing these, critical care roles who really want to do that. Other people really don't want to do that or don't feel comfortable in an ICU. So I think having a plan laid out in advance with what people's interests, skills, or any concerns that they may have is helpful to guide tiers of redeployment and who would go where if needed.
That makes sense.
Can I ask a question? Let's see. I wanted to find out from you, from your projections and your modeling in America, in the US, how soon do you see the end of this pandemic?
I will add my thoughts and I open it up to anyone else. I think it's largely foolish for anyone to predict what the next month, 6 months, or year are going to look like. And the people that I respect the most are the ones that say, we don't know.
That is a gloomy picture. It's quite gloomy.
All right. Well, if that's it for questions, I would recommend that you contact Josh at IVU if you would like to have any other discussion with any of the panelists today. But I want to thank everyone's participation. I think it was, this is the first time we've had a panel discussion like this, and I think it went was very interesting and went quite well. So, but I would encourage everybody to please keep in touch with us. We're very interested in knowing what's going on in your country outside of the United States. We don't get a lot of information, so would be very interesting to know. But I want to thank everybody again for joining us. I want to thank Scott for assembling everybody, and it's good to see everybody is out there and safe. Thanks very much.
Thank you.
Thank you.
Thank you. God bless and keep you.
You too, Dr. Bella. See you, Di.
Okay, take care.
Bye.
Bye.